Good morning, everyone. I am Dr. Ashwati. I am here to present in brief on my paper, Intraocular Pressure, Variations in Rhegmatogenous Retinal Detachment. Variations in intraocular pressure in rhegmatogenous RD has been mentioned in many studies, and most of the theories have been in favor of decreased IOP in rhegmatogenous retinal detachment. Objective of her study was to evaluate the variations in intraocular pressure in rhegmatogenous retinal detachment and to find its relationship with severity, chronicity, type of break, and presence of myopia. Study design was a descriptive cross-sectional study done among patients with rhegmatogenous retinal detachment attending the ophthalmology OPD, with a sample size of 75 patients obtained by the formula of 4PQ by D square. Exclusion criteria included exudative RD, combined RD, choroidal detachment, and those associated with anterior proliferative vitreoretinopathy changes. The basic statistical evaluation showed that the mean age among the cases was 57.32 years, 72% of them were males, 68% had a subtotal RD, 40% had supratemporal rhegma. Coming to the distribution of IOP among the cases, about 42.7% had normal IOP, that is more than or equal to 11 millimeters of mercury. 37.3 had a low hypotony, that is between the range of 6.4 to 10.9 millimeters of mercury, and 20% had frank hypotony, that is less than or equal to 6.5 millimeters of mercury. This table is showing the distribution of factors like age, duration, chronicity, and severity among three categories of IOP, that is normal IOP group, low hypotony group, and hypotonic group. All this shows that IOP is decreasing with increase in age, duration, chronicity, and severity, but only statistically significant association was found in the subgroup of total rhegmatogenous retinal detachment with a p-value of 0.027. Even though most studies are in favor of low IOP in rhegmatogenous RD, in our case, in our study, we found about 42.7% had normal IOP with a mean value of 14.25 millimeters of mercury. This plot is showing that the IOP distribution as well as the median value is towards the lower range in case of total RD when compared to subtotal RD. It is towards the lower range in case of myopia more than 6 diopters when compared to other refractive errors. And it is towards the lower range in case of old RD when compared to fresh RD. And it is towards the lower range in case of those with horseshoe tear when compared to other rhegma. This scatter plot is showing the relationship between intraocular pressure and duration among the subgroups of chronicity and rhegma. In cases with fresh RD, we are seeing a relationship, that is, as duration is increasing, IOP is decreasing. That is, there is a negative correlation with a Pearson correlation coefficient of minus 0.291 with a significant p-value of 0.041. Similarly, among the subgroup of rhegma, those with the horseshoe tear also had a negative correlation with a Pearson correlation coefficient of minus 0.329 and a significant p-value of 0.01. This table is showing the relationship between intraocular pressure and age among the subgroups of types of RD, severity of RD, rhegma, and presence of myopia in more than 6 diopters. In all these cases, as age increases, IOP is decreasing. But only statistically significant relation was found in the subgroup of old RD, where the p-value is 0.012. Even though there are many studies on rhegmatogenous retinal detachment and its characteristics, there is no corroborative evidence to prove the findings in our study, as there exists no similar studies pertaining on IOP variations in rhegmatogenous retinal detachment. Now coming to strengths and limitations of our study, the major strength is that it has got a large sample size even in the subgroups, and limitations, no comparison group, no follow-up. So to conclude, rhegmatogenous retinal detachment is not always associated with hypotony. If hypotony is present, it does not always correspond with the severity, duration, or type of breaks. So all these will point towards a multifactorial pathophysiology in IOP variations in rhegmatogenous retinal detachment. Thank you.
How was the IOP checked?
Ma'am, applanation Goldman applanation tonometry.
And what is the duration of your study?
Ma'am, we collected the cases in the last 1 year.
Time, exact time.
2021, May to December, that range.
And how did you define chronicity?
Hello?
Define chronicity.
Define the chronicity.
Chronicity depending upon the clinical features, madam, depending upon the presence of atrophic retina, any demarcation line or proliferative vitreoretinopathy changes.
Thank you. Thank you.
Thank you.
So my study is, I have found out the association of corneal sensitivity with severity of diabetic retinopathy. So diabetic retinopathy is an underdiagnosed, potentially sight-threatening condition, and it can be an early indicator of diabetic neuropathy. And we lack the tools for measuring corneal sensitivity in a purely objective manner in a regular practice, which is easy, cost-effective, and valid. And there are limited number of studies available that are focused on the evaluation of corneal innervation changes in diabetics. So my primary objective is to find the corneal sensitivity in type 2 diabetics with and without diabetic retinopathy. Secondary objective was to associate the corneal sensitivity with severity of diabetic retinopathy and to correlate the occurrence of sensory loss in diabetic neuropathy as well as diabetic nephropathy in type 2 diabetic patients. So it was a comparative cross-sectional study done over a period of 1.5 years. The eyes of 122 eyes of 61 diabetic patients were studied in the Department of Ophthalmology at our institute. I have included patients with diabetic retinopathy and patients with mild, moderate, severe, and proliferative diabetic retinopathy. And I have excluded patients with corneal pathologies, previous history of surgeries and lasers, and history of any anti-glaucoma or NSAID drugs. So a complete ophthalmological evaluation to establish the diagnosis, biotheciometry to find out the neuropathy, and renal parameters to find out the nephropathy status. Corneal sensitivity was quantitatively measured using the handheld Luno Coquet-Bonnet esthesiometer. With the device, variable pressure can be applied by adjusting the length. It is a monofilament ranging from 60 mm to 5 mm, and as the length is decreased, the pressure increases from 11 grams per millimeter square to 200 grams per millimeter square. So readings were taken at 5 different positions on the cornea: central, 12, 3, 6, and 9 o'clock positions, and repeated 3 times. Average sensitivity was calculated for both eyes of each patient in millimeters. One-way ANOVA test to find out the statistical significance of difference in the mean values of corneal sensitivity with grade of diabetic retinopathy. Independent sample t-test to find out the difference in diabetic retinopathy, nephropathy, and neuropathy. And a p-value of less than 0.05 was considered statistically significant. In my study, the mean age of the population was 59.4, ranging from 40 to 79 years. 43 males and 19 females were studied. And out of the diabetic retinopathy, 38 patients had no diabetic retinopathy, 13 had mild, 26 had moderate, 11 had severe, and 34 had proliferative diabetic retinopathy. And out of the patients with retinopathy as well as neuropathy, there were 2 patients with moderate, 2 patients with severe, and 8 patients with PDR. And those with nephropathy, there were 2 with mild, 2 with moderate, 4 with severe, and 4 patients with PDR. The results I obtained was the mean corneal sensitivity in patients without diabetic retinopathy was 59.61, and those with diabetic retinopathy was 57.59, and there was a statistically significant difference. And mean value of corneal sensitivity in various grades of diabetic retinopathy, out of the 38 with no DR, it was 59.61. In mild, the measurement was 58.77. In moderate, there was 57.69. Severe, it was 57.27, and PDR, it was 56.61. So it was a decrease in corneal sensitivity as the grade of diabetic retinopathy increases. And comparing between retinopathy and neuropathy, there were only 12 patients with neuropathy, so there was a decrease in the sensitivity, but because of the smaller sample size, it was not a very significant difference. And same goes with nephropathy. Again, there was only 12 patients with nephropathy. There was a difference in the corneal sensitivity, decrease was there, but the sample size was small. Long-standing diabetes can cause diabetic neuropathy, tear film dysfunction, epithelial, stromal, and endothelial abnormalities. And these occur due to changes within the composition of the corneal epithelial basement membrane, deposition of glycation end products, damage to the corneal nerve endings, reduced tear secretion, and oxidative stress during hyperglycemic conditions. So comparing my study with 2 other studies, Komolofe et al. Study, also there was a significant decrease in corneal sensitivity among patients with diabetic retinopathy and in increasing severity of diabetic retinopathy. And there was a study by Chitra Raghavan et al., which studied the corneal sensation comparing with neuropathy, and there was a progressive decrease with severity of neuropathy. So there are limited number of patients in the diabetic neuropathy and nephropathy obtained for the study. So definitely a larger number of patients and more data would be required to make an accurate assessment. So the conclusion is that corneal sensitivity was found to be significantly lower in those with diabetic retinopathy compared to those without, and reduced in eyes with increasing grades of diabetic retinopathy, and also in diabetic nephropathy as well as neuropathy. So corneal sensitivity as an adjunct along with diabetic retinopathy screening can be considered for early detection of corneal and ocular surface abnormalities and their prompt management, and also as a marker of severity. Thank you.
What is the oldest patient you have included in your study?
72.
So, is that age?
No, there is a difference between the age, the corneal sensitivity among ages of patients, but I have not considered that in my studies, ma'am.
Okay.
Did you calculate the sample size?
It was depending on previous study that I took. It was calculated according to that.
And why did you include both the eyes?
Because the severity, it is not the same in each. One eye maybe it was severe and one eye it was PDR. So
Did you make a table of that where there was asymmetry between the two eyes? What was the sensitivity difference?
it was not compared in one patient. I was not comparing the sensitivity between both eyes. I just tabulated which was mild, which was moderate, which was severe, and which was PDR, and then compared between those.
What do you think is the reason for change, difference in the sensitivity between the two eyes?
The severity, as it is increasing, I have found that the sensitivity is also decreasing. So in a patient with
No,
mild,
between the two eyes.
depends on the severity of, if it is a moderate in one eye and if it is severe in the other eye.
And what is the reason? Any postulation? Diabetes affects both the eyes simultaneously,
Yes, ma'am.
in the same, no?
What percentage has the asymmetrical retinopathy?
Oh, that I have not found out in the study, ma'am. I'm sorry.
Thank you.
Good morning. My topic is effectiveness of YAG peripheral iridotomy, a retrospective case series analysis. No financial interest in this study. Angle closure glaucoma is a blinding disease, and the main pathogenetic cause behind this disease is pupillary block, and the primary mode of treatment is a peripheral iridotomy. When a person harbors narrow angle with two quadrants of iridocorneal apposition, it's known as primary angle closure suspect. Along with that, when there is raised IOP or presence of peripheral anterior synecdoche is present, it is known as primary angle closure. And when there is disc and field changes are present, it's known as primary angle closure glaucoma. Aim of this study is to study the effectiveness of YAG peripheral iridotomy in patients with narrow angles in terms of angle opening and IOP control. Why this study? The previous studies like Singapore asymptomatic narrow angle laser iridotomy study and Songsham angle prevention study, they are reported effectiveness of laser peripheral iridotomy among the Chinese population. In this study, we are evaluating the effectiveness of YAG PI in our own ethnic population. It is a retrospective analysis and for a period of 3 months from January 2022 to April 2022, and 48 eyes of 28 patients were enrolled in this study. Intraocular pressure was recorded prior to YAG and immediate post-YAG and 3 weeks after the procedure. And gonioscopic angle width was recorded before and 1 month after the procedure. Coming to the result. This table shows a sex distribution in our sample. Among 28 patients, 9 were male, which makes a percentage of 32.1%, and 19 were female, which makes a percentage of 67.9%. This pie chart shows the distribution of hypermetropes in our study group. In our study group, 65% were hypermetrope and other was 35%, which composed of emmetropes, myopes and astigmatic patients. This table shows the average IOP. The average baseline IOP was 60.54 plus or minus 9.1. And average immediate post-YAG IOP was 18.15 plus or minus 6.92, and average IOP in post-YAG 3 week was 15.56 plus or minus 4.8. This shows the average change in IOP. The average change in IOP from baseline to immediate post-YAG PI was 1.6 plus or minus 9.1, and the average change from the baseline to post-YAG at 3 week was 0.98 plus or minus 8. This is a dot and plot chart which shows the mean and standard deviation of the IOP. This shows the angle with changes. The superior quadrant was taken as the first quadrant, and the nasal quadrant is taken as the second one. The inferior is taken as the third quadrant, and the temporal one is taken as the fourth quadrant. In first quadrant, among 47 eyes, in 15 eyes the angle was opened up, and in 32 eyes the angle width stayed the same. The same change can be seen in the other three quadrant also. From these tables we can get a conclusion that about 1/3 of patients they showed the opening of angles, and in about 2/3 of the patient there is no significant change in the angle. This is a pie chart showing the change in angle width. There is no change in 62.5% eyes, and there is change in 37.5%. Discussion. This study underlies the fact that the laser iridotomy does not open up all the angles in all cases, so that gonioscopic follow-up is needed in patients who underwent YAG PI. And in Vellore eye survey study, 11% of post-PI primary angle closure progressed to primary angle closure glaucoma, as opposed to 36% who refused peripheral iridotomy. And in Songsham angle prevention, the risk of primary angle closure was estimated at 4.19 per 100 years with a PI in place, as opposed to 7.97 without a PI. In a symptomatic narrow angle laser iridotomy study, 5% developed primary angle closure from primary angle closure suspect with a PI in place, as opposed to 11.65% in the absence of a PI. So that risk reduction in both of the studies are 50%, so that laser peripheral iridotomy has a protective effect in primary angle closure suspect. However, all angles does not improve with the laser peripheral iridotomy, so that the clinical follow-up including gonioscopy is necessary in patients who underwent YAG PI. These are my references. Thank you.
So all your patients were PACS patients?
No ma'am, among that primary angle closure glaucoma patients were there, and 7% was primary angle closure suspect ma'am.
And your 3-week follow-up is enough to draw this conclusion?
In the 3 weeks period, we observed that in some of the patients the angle was opened up, and in 2/3 of the patient it was stayed the same.
So what more investigations you did when the angle did not open up?
Maybe because of high lens vault and the plateau iris was present in the other patients.
So then the thing is that they are all not pure primary angle closure cases. So it is that there is other elements contributing to the angle closure.
Yes ma'am.
But do you expect an angle to be opened in a case of primary angle closure glaucoma? You expect the enough peripheral anticyanic is already formed. That's why it has gone into a glaucoma stage, no?
Yes ma'am.
So in those cases, the angle is not going to open with the iridotomy. Am I right?
Yes ma'am.
Yes.
Thank you.
Next.
Good morning, everyone. My topic is prevalence of glaucoma among the referrals from outreach camps in rural areas of central Kerala. Glaucoma indicates a number of neurodegenerative diseases having in common a progressive optic atrophy, finally leading to the characteristic optic up neuropathy and to irreversible visual field loss. Glaucoma is the second leading cause of overall blindness and the most common cause of irreversible blindness worldwide. Glaucoma is often referred to as the silent killer of vision, as it is asymptomatic in the early stages except for angle closure disease, and it's irreversible, that is, damage that has once happened to the retinal nerve fiber layer cannot be repaired. So what exactly is the prevalence of this glaucoma in Kerala? The fact is that authorized data is lacking regarding the prevalence of glaucoma, which is a real matter of concern, especially for a state like Kerala with good performance records in healthcare delivery system. Our institute conducts peripheral outreach camps as a part of community ophthalmology, in which the patients detected with defective vision due to causes other than refractive errors are referred to our institute for its management. Patients screened in this way after reaching the institute undergo detailed ophthalmic examination, and my study involved the detection of glaucoma during this investigative workup with the advantage of nil added expense or effort for the patients. So my methodology was very simple. The patients who were referred for detailed evaluation, whenever indicated, was evaluated in detail by glaucoma specialist, and a diagnosis of glaucoma was confirmed by HFA 24-2 and OCT-RNFI. Moving to the results, I could collect a sample of 134. About 46% of the sample belonged to the 61 to 70 years age group. Females predominated the sample. There was no significant correlation between the presence of comorbidities like diabetes, hypertension and glaucoma, no correlation between refractive errors and glaucoma. Almost majority of the patients had deep angle of anterior chamber. About the prevalence of glaucoma, 16 individuals, that is 12% of the study population, had glaucoma in one form or the other, and the primary open angle glaucoma was the most common form. Only one patient was already a known case of glaucoma, and all other cases were detected by our evaluation. That is, the prevalence of undetected glaucoma was nearly 11%, which is really alarming. About the cup-disc ratio of glaucoma patients, 3 patients had nearly total cupping, indicating very advanced disease. And about intraocular pressure, almost all of them had moderately high IOP, except for one who even had an IOP of 61 millimeters of mercury. 2 patients had no perception of light in one eye due to glaucomatous optic atrophy, and 4 patients were found to be unilaterally blind due to glaucoma. That is 2.98% of the study population, where we define blindness as a visual acuity of less than logMAR 1.3. Moving to discussion, the overall prevalence rate of glaucoma of 11.9% is drastically higher than the rates obtained in population-based studies like Vellore study or Chennai glaucoma study, which is quite obvious in that mine was not a population-based study, but rather I examined the patients who presented to us with defective vision. Also about the prevalence of undetected narrow angles, compared to study by Varma et al., my population had lesser prevalence of angle closure disease. And the rate of blindness was much lower than that observed in Chennai glaucoma study, but higher than that observed in West Bengal glaucoma study. The limitations were my sample size was small, as it was conducted during the first wave of COVID pandemic, and the number of camps was significantly restricted then. And the visual fields could not be reliably done in those patients with vision less than logMAR 0.602. A best corrected vision during the course of the study period was considered irrespective of the cataract status of the lens, and many patients were lost to follow-up after cataract surgery in one eye despite adequate counseling regarding the need for review. So to conclude, a finding that more than 90% of the cases were previously unrecognized is a real matter of concern, especially for a state like Kerala. Even though this value cannot be directly extrapolated to the general population, it does urge the need for revision of existing ophthalmic screening programs and implementation of new schemes for awareness and primary evaluation of glaucoma also. A routine ophthalmic evaluation should be made compulsory after 40 years of age, so that we can get to the base of the iceberg glaucoma burden and save many thousands of patients from turning irreversibly blind. Thank you.
Number of camp patients you screened, total camp patients?
Total number was 565.
Of that, how many were
That I excluded those with pure refractive errors, those who had corneal or retinal pathologies. I took the remaining.
Correct. So you referred this patient to the base hospital based on what?
Ma'am, those whoever who was not improving to 6/6 with refraction.
Visual acuity is considered then,
Yeah, ma'am. Only vision.
or fundus examination was done?
No, ma'am. At peripheral camps, we don't do fundus examination. We purely refer them based on the visual acuity only. So that's my implication. We have to bring methods for like fundus camera or portable tonometry also in the camps.
Even the advanced glaucomatous cupping, you can have 6/6 vision.
Yes, ma'am.
Yes, so there's no point in
Visual
taking patients with low vision or
Based on visual acuity only.
based on
yeah.
visual acuity only, you cannot select a suspect.